All right, we are live on Facebook.
All right.
Well, I'm excited to be back. Dr. Hyland, isn't this pretty awesome? We've got another great guest tonight.
Yeah, Dr. Sharif. And tonight we're bringing to you a philosophy of care that ties together periodontal care. It's about biofilm control, how you get your patients to do their sulcular cleaning. It's about testing for the bacteria that cause disease, if that's what you'd like to do. It's using something to kill the bacteria. That can be an antibiotic mouthwash, which tackles the whole mouth, and the use of lasers. And that's our focus tonight, to kill the bacteria and to reduce pockets, because we have to deliver 3 to 4 millimeter pockets to our patients predictably, because without that, they can't cure and maintain the health of their own disease. And in particular, when we look at the landscape, our focus has been on procedures rather than prevention and intervention. And the result is that 85% of patients still have gums that bleed. And so we want to present some ideas on how to overcome those obstacles. And we'll bring together a hygiene, a dentist, and a dentist that does a lot of laser dentistry in LANAP. Dr. Jim Hyland, IDL member for about 6-8 months now. Clinician, still work 2 days a week, president of Aura Vital, and love sharing my my knowledge. You work with Carrie, who is my daughter. We've worked together for 22 years, Carrie.
Yep, I'm a hygienist and still work clinically as well. I do a lot of education. I'm a KOL for Creston Oral B. I work with Aura Vital. I work on, and I'm on a few different talk shows. So lots of background and knowledge in that aspect. And today we've got Dr. Sharif joining us, which is so exciting. Can you just introduce yourself to some ILD members if they haven't followed you or know who you are at this point yet?
Okay. Hi, Jim, and hi, Carrie. First of all, thank you very much for inviting me to this forum. I find it lovely and very informative. Let me introduce myself. I am Sharif Radwan. I'm a practicing dentist in New York City and the area around the metropolitan. I have 3 practices. Basically, I do all phases of dentistry, just about. Except orthodontia. But also, I stumbled about 6 years ago on the laser treatment. Historically, I always thought the laser is just a glorified electrosurgery. Boy, was I wrong. I discovered that there are so many great uses for laser in dentistry. Today, we're specifically gonna be talking about the LANAP machine, or it's called MVP7 machine, that is made by Millennium Dental out in California. It's American made. It's a great machine. It has so many uses. We're gonna try to narrow it today, focusing on the bacteria and saliva, gum disease, even though it has so many other uses, valuable uses. Very bad. Like, to me, as I was telling Carrie and Jim, that I walk into my office in the morning and I turn my machine on, because somehow, somewhere, I'm going to use that machine today. And I'm going to make somebody happy. I'm going to make me happy, because when I look at successes in what I do, that's when I become really happy, and I know that I made a good investment in the machine that I bought in. Now, just to go quickly through what I'm going to be speaking about. Okay, so we have something that always creates a problem, which is saliva, hard tissue, and bacteria. Whenever these 3 items are together, trouble. Saliva, bacteria, and hard tissue. We always end up getting some sort of a plaque formation, whether it's intraoral or extraoral, same thing. So traditionally, over the years, I mean, it's like we share the responsibility of controlling the bacteria in the patient's mouth between the dentist and the patient, and the hygienist, obviously. Hygienist, as you, Carrie, you always lecture patients on how to clean, how to floss, how to control bacterial population in their mouth, because that's very important. If you cannot control that, it's a losing battle. So traditionally we have toothbrushes, toothpaste, tongue scrapers, and we had mouthwash. Now, also there is a very important factor that patients started to know about it now, which is the relationship, the very dangerous relationship between heart disease and bacteria in the mouth. Because that bacteria gets through the sulcus, gets into the bloodstream. Patients that have subacute, like they have artificial valves, they have artificial joints, actually, they have subacute bacterial enteritis, they end up having major problems with this bacteria if it's not controlled. Now, what do we have as dentists to control the bacteria that we have? We have the cavitrons and piezos. We have hand scaling and replaning. We have osseous surgery. And we have debridements. Then we have a very good weapon that actually helps us through this, which is the laser. Now, when we say laser, there are so many different lasers. And depending on the laser that you purchased, it all depends on, I mean, they have, it's obviously it's very complicated to get through it. You have the Nd:YAG, you have the erbium, you have the diode, you have so many of them. However, the one that actually works on bacteria and soft tissue, the most effective one is the Nd:YAG machine, which is the MVP7, the LANAP machine. The way it works is it has a wavelength of what we call 1064, and that targets the P. gingivalis. All right, so P. gingivalis is a pigmented bacteria that causes a lot of damage to the periodontium, sulcus. So if you can actually selectively target that bacteria, so here you have a very intelligent device. You're selectively targeting that one bacteria that causes so much damage and is precisely responsible for gum disease without damaging the rest of the tissue around it. So it's almost like a smart bomb. You just like direct it and it goes in and it just kills what it's supposed to kill and leave everything else untouched. Versus like if I take, let's say, a diode machine, basically I'm just like burning everything off. All right, good tissue and bad tissue and bacteria and everything in my way. I'm just gonna burn it off. That's not what we want to do. We want to preserve tissue. The idea is to preserve healthy tissue. That's when that LANAP machine becomes, very effective tool in controlling your bacterial population in the sulcus and the saliva. So how actually the LANAP machine is the only one, just because the histological studies showed that you actually, with the proper protocol used with the LANAP machine, you end up creating new attachment. And the new attachment, as I said, is the new cementum, new periodontal ligament, and new bone. So, and even when you say that, sometimes it's just like, I still till now, I just can't believe that I see it on a daily basis. And it's not just a fluke. It does happen all the time. I mean, I can see it over and over and over. Patient, I mean, it's like some wild cases, like you say, yeah, a patient that walks in and you take a PA on that tooth. All right, let's give me some Novocaine and a pair of pliers. Let's get those babies out. No, not necessarily.
Yeah, we think it needs hospice care. Now, something you've intrigued me with, and this may explain, I send my patients basically only to periodontists that use LANAP. Okay, so
Right.
that I'm totally in.
And
So
that's very
I send cases off and they go, I'm going to save that loose tooth. And I'm going like, I don't want them to spend $2,000, $3,000 and then have to pull it out and spend that much on an implant again. They're going, no, it's okay.
No.
And what intrigued me was you said it develops cementum.
right?
Well, if it develops cementum, now I can see how you can rebuild bone levels. But
Yes,
till I actually heard that, it didn't make as much sense to me. So that's big to me. That's big.
that's the whole idea about it. You are the regeneration you get, and here that's what we got from the FDA clearance. It said that through regeneration, which is new cementum, new periodontal ligament via Sharpie's fibers. So you get in the function of the periodontal ligament, and then you get new alveolar bone.
Okay.
That makes sense.
That's incredible. That I'm gonna show you here. Let me just skip here, and I'll show you a couple of pictures where traditionally you and I would get that patient tell that patient, sorry, too late, hopeless, let's get this puppy out. And by the way, give me some bone and some membrane, and let's do some graft, and later on we're gonna place an implant. Look at this.
Oh my gosh.
Look at this. How many, who's in his right mind would want to try to save this? So
I don't know. That has to be a crazy person. Okay.
right. Look at this. This is after a year.
Yeah.
And this
Now,
is,
there was no perio-endo involvement there, right?
well, there was no
Wow.
it just pure perio. And you have 3 years post-op pictures, a solid bone that filled in between the two roots of the tooth. And here you have 6-year post-op. Now, the greatest thing about this technology is it's not that 3 months and okay, let's take an x-ray and okay, we're done. No, that procedure keeps working for you for 2 years, regenerating bone. And the studies showed that obviously this is just one tooth being treated here. We do entire mouth. Like instead of sending the periodontist for 4 quads of osseous, we do 4 quads of LANAP. Every single tooth gets treated. Actually, that's what the procedure is. You have to treat every tooth in the mouth. So for 2 years after that day you did the procedure, you continue to regenerate cementum, new attachments, bone, alveolar bone, and periodontal ligament. So it's incredible.
In a case like this, one of the keys with LANAP is doing occlusal adjustments.
Absolutely.
Because we have to control stress on teeth and have to control infection. And what do you do to control stress in a tooth like that?
So you have a couple of things. Number one, well, first let me tell you what LANAP stands for. It's, or I'm sure you know, but just for the audience, laser assisted new attachment. The last P stands for protocol. It's a protocol. You cannot pick and choose. You cannot say, I'm going to do this part and skip this part. The last part, yes, the last part of the protocol is heavy occlusal adjustment. Heavy occlusal adjustment. So traditionally what we do is we do half the mouth. So by doing so, I'm using one side as a crutch. And while you are using this side that I didn't touch, I heavily adjust the occlusion on the other side. Now I know, but in our training, at least in my training, occlusion was not big. It was not heavily discussed as dental students. I was a dental student 32 years ago, but it wasn't. So, but now everybody knows that stress that is caused by premature occlusion is an incredible force of destruction. It destroys the periodontal ligament. It creates a lot of fremitus. It creates a lot of gum recession. It creates actually, it can make the pulp tissue or nerve tissue die inside the tooth because just premature contact. So yes, part of the protocol of the LANAP is, which is the last part of it. Right. After you're done, you have to level your occlusion. So You don't create any undue stress to the teeth, so you don't break it down again. Let me show you another. Look at this.
Wow.
I'll go like this, okay? I'm impressed.
So,
And I'm hard to impress. That's fantastic.
so you do something like that. Now, if you notice that we use always with these cases, splinting.
Yeah.
That's
Yes.
the second part that we use. Now, on the back molar that I just showed you earlier, what we do is sometimes we do temporary stabilization. Like I get a thick, heavy wire,
Mhm.
and I just run it across 2 or 3 teeth and just
Yes.
dot composite everything. So it gives me a temporary hold. I mean, obviously it's not very aesthetic and it's not very comfortable to the patient. However, it's very effective in reducing movements. These micro movements that happen, or many movements that happen, it delays healing. But if you can somehow get it out of occlusion and stabilize it through a retainer like this, you permanently
Well, this tooth can't heal. You
It
can't
cannot heal.
develop, if the tooth is moving
It
all
doesn't
the
heal.
time, you can't develop an attachment. So I mean, it
Exactly.
just makes sense. Okay.
You're breaking the attachment every time you try,
Yes.
it tries to happen. So you stabilize it. You must stabilize your loose teeth. Just
And I
like,
think that this comes down to protocols, because when I hear that people have said, well, I've tried lasers, I've tried these different procedures, they didn't work, they just didn't follow the protocol.
exactly.
Yeah.
That's it.
That's really what it comes down to. Even in the hygiene, it's like we have to have these protocols. They're there in place so that we will, get the same results the literature says.
That is exactly my point. It is not just pick and choose what I can do. And no, it doesn't work that way. It's like a patient comes to you, you clean their teeth, they look beautiful, and then they go home. Oh, I clean my teeth, I'm done. No, you're not.
No.
You're just starting.
Yep.
So your work is just starting. It's not because you just had your teeth cleaned, this means that it's done. It's a protocol. You do your part, I do my part. So my part here was to clean the tooth surface, make sure that it's done. Then the first pass of laser is called ablation. What is ablation? Is basically you cleaning the surface, the epithelium of the sulcus and you get rid of the dead bacteria and the bacteria that you just killed, and the granulation tissue, what have you, all of that. Then you go in with successive scaling and root planing with the different attachments on the piezo. Each one is specifically designed to do one thing and one thing only. The last one of those attachments on the piezo, it does what we call blunt dissection. What's a blunt dissection? It basically scratches the bone all around. So you're changing the morphology of the bone. And by doing so, you're scraping the bone, so you're creating new blood pools coming out of there with growth hormones in it, growth factors, I should say.
Yes.
And that is what is going to help you. So as I said, it's a protocol. Do not skip.
Yes.
You just got to do what you're supposed to do. You have to do it. I mean, I need to speak to the folks out in Millennium, because what they do is your first boot camp, it's like 4 days of really brutal training. And then they give you the machine and they give you a certificate in your hand. All right. So now you're licensed to use it. However, there's still 3 more training levels. A lot of people, they skip it. That's it. I got my machine. I'm certified. Let me go play. During those 3 boot camps, they really hammer it in your head.
Yeah.
That it's a protocol. It's not a procedure. It's a protocol. You got to follow it. And by the time you're done with your last protocol, you're an expert. You start to get cases like this or results like this on a daily basis.
Well, what happens, what you're describing is you expect to get results like this.
Absolutely.
As opposed to most people, it's got a cowboy. Let's see what I can get away with.
Let's
Okay,
hope.
you don't want to be a cowboy.
It isn't.
Patients aren't coming to you for that sort of care. Yeah.
Absolutely, because you're charging good money for this. So
Yeah.
you gotta deliver. And the only way you're gonna deliver and get continuous improvement and bone levels, increased bone levels, is by following the protocol to the T, to the letter. You don't skip.
But you know, an interesting thing, you've talked about the importance of scaling and root planing.
Yes.
But what scaling and root planing does not do is kill and remove bacteria.
That
It
doesn't.
disturbs it. So it slows the process down, and then 6 weeks later, it's reorganized and you start the same thing all over again.
Absolutely.
And that's why scaling teeth doesn't prevent disease. It slows the process. You've got to tackle the bacteria. And so, right
As
on.
you probably in your practice, you notice that after you do scaling and root planing, patient walks in for whatever reason, I need a filling, I need a crown or whatever. You start to see bleeding gums. Even though you just cleaned it 6 months ago, you didn't even clean it. You scaled them. But again, with the scaling, you did not sterilize the area.
Well, that reminds me of an interesting study. I know it's an older one. I think it's from about 2007. It was published in the Clinical Journal of Periodontology, and it talked about bacteremias after scaling and root planing, after SRP. And, you know, the study showed that 80.9% of people had a bacteremia after SRP, immediately after.
Yes.
And the thing that I find scary as a hygienist is that 19% still had that positive cultures after 30 minutes.
Yes.
Well, and what were they looking for? They were looking for the P. gingivalis that you talked about. They're looking for fusiforms. They're looking for AAs. These are what we need to be talking about. It's more than just scaling and root planing. We've got to blast away that bacteria and figure out what it is that we're looking at.
Yeah, this is such a great study. And again, P. gingivalis is your biggest enemy. That's what makes us look bad sometimes, but that's what we need to go after. And by using this particular LANAP protocol, you are specifically targeting that P. gingivalis and you kill it.
And also for a hygienist using the system, if they're disinfecting the mouth with a laser,
I'm gonna get to this.
You're gonna get to that. Okay.
Right.
Go ahead.
So again, just to go on the protocol again, this slide shows the last use of the laser machine when after you remember we said you go and you do the ablation first, then you scale and you do the blunt dissection. Now, okay, so I cleaned everything and now everything is sterile in there. I cleaned the sulcus. Don't forget that laser beam at the tip of the beam, it travels 6 to 8 millimeters beyond that. So you can go as far as you want with that. So now I need to seal around that tooth, to seal that sulcus so nothing gets back in it. All right, I wanna keep the bacteria away. So this is, you have a setting, which is the second pass of the laser machine that does this thing for you that we call it the fibrin clot, which is basically a clot that forms within 2 to 3 minutes of your procedure. And it seals the sulcus. The sulcus is sealed, 100% sealed. There is no bacteria going back in there. There is no saliva going back in there.
Right.
Nothing. It's sealed, as you can see. So by doing that, you created the perfect environment for healing. Sterile environment, bacteria-free, sealed, free of stress by removing the premature contacts and by splinting the moving teeth. And you got a perfect storm. Few months later, you take an X-ray, you see that very big smile on your face as a dentist. A lot of it, I just had a judge that she had an implant that literally had 0 bone. It was just floating just like this tooth. I should have brought her X-ray too. and it was just floating like this, nothing attached. And the only reason why it stayed in her mouth is because through the crowns, it was attached to another implant in the mouth.
Okay.
Right next to it. It was tooth number 30. So 31 was still had like 40% bone. And she comes in and she was referred to me to remove that implant and bone graft it and put a new implant. So I told her about my toy. And I said, you're intelligent enough. Would you allow me to try to save your implant? She looked at me and she said, it's impossible. I said, just let me try it. And man.
What's the sentence if it doesn't work out?
For 3 months, after 3 months, I asked her to return. I had a 50% bone growth on that.
Wow.
Implant. 3 months. So I showed her my slide and I showed her the x-ray. And she said, am I going to make the lecture circuit here? I say, yep. Whether you allow it or not, Your Honor. She said, approved. So, yeah, so that's what I mean by protocol. Just follow the rules and you will be pleasantly surprised. Here, look at this case here. Your pre-op, just like disaster. And that's right after you did the surgery. And that's 1 week after we did the surgery. And by the way, this happens every single time. Every single time. To the point, honest to God, when I was first trained on it, I would take a double look at the patient. I would run to my computer screen to make sure that I'm looking at the same person.
Yeah.
Do they have the right patient on my chair? This does not look what I just saw a week ago. This is just a different person, a different texture, different everything. So as I said, you do the protocol, you will consistently get this result. In 1 week, patient comes back 1 week. By the way, in 1 week, they come in and I readjust their bite because it happens because of the edema from the surgery and all of that. Teeth shift a little bit here and there. So again, just take a articulating paper and just like realign the occlusion. And again, these patients, they become very, very happy. Here also, the other thing is with the this is the fibrin clot. After a few days, it starts to look like that. It gets that grayish look to it. Now, again, it's still sealing the sulcus. If you look at it, there's nothing going in, and no recession, none of that. So again, you end up having beautiful results consistently. Now, let me just, I know we've been talking in the past 30 years, there have been, I don't know, over 2 billion implants placed, or 1.5 billion, something like that, some obscene number of implants placed. Every year, millions of implants are placed across the globe. Now, the problem is, at the beginning, everything is good, it's like everything is beautiful, blah, 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 but implants do fail. And the reason why they fail is, it's the same reason that your teeth fail. Same thing. As a matter of fact, implants fail a lot faster than natural teeth. Why? Your natural teeth has a natural defense mechanism called periodontal ligament. Yeah. Implants don't. Implants don't have periodontal ligaments. So you lose that one layer of protection. So what happens is a patient like this comes in and a dentist is happy. I placed that implant 5 years ago, 7 years ago. It's still functioning. I still got like 80% bone level on, bone surrounding the implant. But is this, do we consider this a successful implantation? It depends who you talk to, and it depends what your definition of success is. Now, it looks like this on the X-ray, but in the patient's mouth, this area is not very hygienic. It's red, it's bulbous, it's bloody, it has bacteria, it smells. It's not really, I mean, even though the implant is not has not failed, and it's not mobile, and it's not this, but this is a failure or beginning
And the
of
success, it isn't just how long does it last, it's how
no,
healthy it is. And
how healthy it is.
yeah.
So
So to me, I talk to people, I tell them an implant's a bit like a nail in concrete, but a tooth is a nail in soft wood.
exactly.
It's got some give to it. So the occlusion is important. And the other thing I tell them is a tooth is like a buttoned up collar around the gum. But when you got an implant, you got a
Exactly.
turtleneck. And
Yeah,
so you got to teach them to clean that area. And these are good terms you can use in talking to the patient. So is
absolutely.
it safe to use a laser around an implant?
Absolutely. The procedure is exactly the same. It's called LAPIP.
Okay.
What is that
Laser
called? Say it one more time. It sounds so nice.
LAPIP. And LAPIP stands for laser assisted peri-implantitis
Okay.
protocol.
Okay.
ASP is always protocol.
Yeah.
It's the same exact. However, you just gotta use a little bit less energy. Why? Because the surface of the implant is metal, so it acts like a mirror. So you get double action.
Okay.
So you gotta reduce the amount of laser beam that you're, or the amount of energy that you're directing toward the tissue, or else you can fry it. So you gotta be more careful with implants. However, it's the same exact procedure, the same exact level of caution when you work with it. Again, failures, okay, the implant is not moving, and maybe there is no pus coming out of it, and there is no infection, there is no swelling, yet it's not healthy. If you leave it unattended like this, I guarantee you in 2 or 3 years, that implant will be gone. It'll be just floating, because it just like progressively gets worse and worse, and it keeps going after the bone and just like destroys it.
Do you have a post-op on one of those?
See, Mariah can lose her lunch now because
Mariah was helping us get things organized before. So Mariah, you're not going to lose your lunch. We'll email him and remind him that you're going to.
Some of the things, if you're not using lasers, I started using a laser back in 2000. They sent me home with the laser. It was a water laser. I had no instructions but the manual. And they told me it was 3 months before the person can come up from Arkansas. I practice in Ontario, Canada. So I just opened it up and I started using it. You know what? He told me some interesting things. He said, it doesn't hurt to cut the tissue. I'm going, really? He said, you'll have no swelling afterwards. I said, come on. He said, there'll be virtually no bleeding. I said, I don't believe this. And he said, there'll be no scarring. So I thought, okay. Monday, I go into the office and I wear my swimming trunks because I've got a cyst on my leg. Carrie was there. I pulled out the laser. I got my assistant and she had the suction down. It was by my knee, thank goodness. And she's got the suction going. I cut a cyst out that was 7 millimeters deep and 5 millimeters across. No anesthesia.
wow.
It was a little pinprick, but totally bearable. The only thing I forgot was that when I started to move around in that location, it might bleed. So I had to keep changing the thing. Then I started using it in the mouth. And I mean, I'm taking lumps off the tongue and lumps off the cheeks that are like 6-7 millimeters in diameter. Doesn't hurt.
Yeah.
Then I start doing frenectomies. I mean, you cannot do a frenectomy with a scalpel. You can't. What I do is I take care of the patient and then I give the parents the painkillers and tell the kid to take care of the parents because they're so upset. The kids are going like, what's the problem? It doesn't bother me. Am I not right?
Yeah,
So you
you're
do full mouth
100% right.
surgery for these people and it's like, they love you.
Yeah.
They don't have the
absolutely.
stitches. They don't have the post-ops. They don't have the pain, the swelling, and they have no scarring. You've taken skin tags off, haven't you?
A lot.
Like 116 was my record. No scarring.
No scarring.
Should have been I did something.
It's okay.
Yesterday,
I should have been what do you call it? A plastic
Apology.
surgeon.
We have, I'm telling you, I removed mucoseals with it. I've removed
Yes.
fibromas with it. I removed
Well, canker sores,
canker.
you know, that
Canker
sort of
sores are
thing.
my fun.
What do you call it? Herpes?
Canker sore are my fun part
Yeah.
because a patient walks in, oh my God, it's so painful. I cannot eat, I cannot touch, I cannot this. And literally with this machine, I swear, 5 minutes, that
Gone.
thing is gone. Doesn't even
Speaking
exist.
of 5 minutes, we have no more than about 5 minutes, okay? So
Yeah.
we'll keep
So
it going.
again, here, it's like, as you can see, you got like 7-8 millimeter pockets, and you do the procedure and look how nice and clean and healthy. And again, the most impressive thing that really impressed me was there was always no recession
Yes.
because you're not cutting away tissue.
Right.
You're only targeting bacteria. That's the difference.
When I looked at that picture of the lower anterior with those tissues swollen up, I figured you were doing a gingivectomy first and then you were going to do things.
No.
I can't believe you left that. Okay.
No, we don't touch, we don't get a scalpel, we don't cut anything with the laser, you just attack the bacteria
Okay.
where it lives. It lives right in the sulcus, and you're just gonna go after it and you're gonna attack it. As a matter of fact, while you are working, I forgot to mention this, while we are scaling, you get lumps of granulation tissue trying to come out of the sulcus. Push it back in.
No.
Yes.
Okay.
You push it back in. I don't want to lose it. Why do I want to lose a tissue? I'm just going to sterilize it, and it's just going to be part of that structure around the tooth, and it heals beautiful. It heals beautiful.
Can you help me with my hygiene head and my hygiene mind right
Okay,
now?
I'm glad you mentioned that. We shouldn't close before we talk about hygiene.
No, I want to make sure that we highlight how we can help or give information for the hygienists that sometimes get these patients that have had LANAP or education for
Great.
them, because really we are the gateway to ensure that this is maintained.
Exactly.
And then we've got that communication. Not that you guys can't do that, but
No.
usually it's on the hygiene side.
So with the LANAP machine, what they have is they have a low dosage. It's a 2-watt output for the hygiene. And basically what it does is it disinfect after you do your cleaning and you clean you remove the plaque and the whatever you have, the calculus, anything you have inside that sulcus, and you removed it. Now you want to disinfect that area. You don't want it and back to what we used to talk about, the bacteria going into the bloodstream. So as a hygienist, you going in and you are cleaning, disinfecting that sulcus very thoroughly around. It's going to take you probably extra 7, 8, 10 minutes, maybe at the end of the procedure. However, what you are doing, you're doing such a great service to that patient by disinfecting that sulcus and reducing the bacteria and the biofilms around that area. So it's not only that we're removing clumps of bacteria, no, but we're disinfecting as well. And that's very important. That's what's going to create the healthy periodontium around the tooth.
So hygienists, then when they come in, we can use the laser, which I truly think is so amazing in all aspects. Even if someone couldn't have LANAP, if you've got a laser there, figure out how to use it. It's so helpful for all that we do. What about home care, like as far as rubber tips, water picks, brushing? What do you suggest for patients that have gone through this?
It's a whole program. It's not just, as we say,
it's a protocol.
Just remember the word protocol. P stands for protocol for everything.
Yes.
So I'm going to get the patient to understand. And my biggest ally and my biggest helper is an educated patient.
Right.
So when I love it when my hygienists spend that extra 5 minutes just trying to explain why we do this rather than do this.
Yeah.
Okay.
Yeah.
You tell somebody do this, they're going to do it 2, 3, 4 days and they're going to quit. You're going to tell them why you want to do this. That's, you got a patient understanding for life.
Yeah.
they become obsessed with it. So you're gonna tell them, why do I need to use a piece of floss? We're gonna explain to the patient, why do we need a piece of floss? A rubber tip. What is the function of a rubber tip? How do I use it without damaging any of the tissue? This is a very delicate tissue, so it needs to be treated as such. So as either a dentist or a hygienist, I always reiterate what my hygienist tells my patient. This is how we're gonna clean your teeth. How you going to clean your teeth? It's a reciprocation. You do your part, I do my part, and together we will maintain your
If
healthy.
I can summarize things, bring things together. We've talked about hygiene, general dentistry, and a more specialized area that you're doing. But it comes down to biofilm control.
Yes.
And it comes down to committing the patient to be involved in getting themselves healthy with the proper information, creating an environment that they can then maintain however you do it. But if you're just cleaning teeth, you're preserving disease. You are not helping
doing
people
enough.
get healthy.
Couldn't say
So
it better.
this is what we're trying to present, Carrie and I, the different ways of engaging with patients. Your approach has been LANAP. We've used antibiotic mouthwashes and things like that, but it's all things together that work differently for different people. We
Right.
need to explore. And, you know, I would say if I was a dentist that was beginning in practice, I'd like to learn implants, but I think I'd like to learn LANAP right away.
Absolutely. And that's what I tell I have a lot of my friends' kids, they become dentists. They are young dentists. They just got out of school. I tell them, first thing you do before you learn anything else, go learn this, because it's going to help you tremendously understanding a lot of procedures,
Right.
not just implants, not just gums, a lot of things. And also it's going to help you maintain your patients in good health. That's what is very important. You need to maintain good periodontal health through hygiene, through you as a dentist. You always have to walk in. And also, I always tell my hygienist, come and give me a heads up. What am I up against? If this patient cooperative, not cooperative, does they do what they supposed to do? And if they're not, I go in and I tell them, okay, right. So I need you to listen to Carrie's method, and why she needs you to do this, and why we need you to have a healthy gum. So, but my experience is when you make the patient understand why we ask them to do a procedure, we do it willingly. If we just tell them, oh, brush and floss, okay, everybody tells them that. Their mother.
Yeah, they have to be participatory. They've got to be involved. I try to use the big word and I can't say it at this time of night, but they have to be involved in the situation. And I think right now in the US and in Canada, the hygienists and dentists, everyone is burnt out. It's hard to find people to work. And this can be an opportunity if you're a dentist watching to expand, to excite your hygienist, you know, do it together, come up with these protocols, because the x-rays that you're showing is what we see when patients go in and they get this procedure done. We see it day in and day out. It is that protocol, it is predictable, and patients want to know that you're offering something that's predictable and interesting. And my friend Beth Parks and I, through RDHU here in Ontario, we're doing some laser, we did LAPT and LBR and bacterial testing. So we took some samples from before, lasered and after, and we're just waiting for those results. But I'm so excited to kind of do some stuff, bring some stuff forward again, trying to excite hygienists to just, it's not just about the scaling and root planing. We've got to go after that bacteria. We've got to count it, measure it, motivate the patient, and reduce it so we can have healthier people. So it is. There's
the theme, the whole thing. It's a procedure that involves bacterial control. So keep that in mind. We've kept you a little longer tonight. I've learned some stuff. I mean, I've been talking with Sharif ahead of time, and he gave me some more diamonds tonight. Look forward to seeing you on the next presentation.
Absolutely.
Sharif, thank you for being involved.
Thank you for inviting
IDL
me.
for giving us this opportunity to do some presentations.
I honestly enjoyed every minute of it, and I can't wait till I do another one with you guys.
Wonderful. Have a good night, everybody.
Good night, everyone.
Good night.
Good night.